Right. Thank you all for coming. I think we're gonna make a start. I know some people are running late today. I know it's Eid today, so it's a happy Eid to those celebrating. We are running a few minutes late with our guests, but I thought I'll make a start if that's okay. I'm Dr. Sham Sabri. I'm a GP. I'm a GP in Bromley. I'm also a GP SI in mental health. So I'm a GP with a specialist interest in mental health. Mental health is my passion. It's the work I do, but I absolutely passionate and really dedicated to that. So without further ado, we're just going to begin. If everybody can tell me, can you see my screen, everyone? Can everyone see my screen? Yeah, I can't see the chat. So if anyone can just shout
Yeah,
out.
we've got it.
Yeah,
Looks
lovely.
good.
Thank you. So mental health is
Yes, fine here.
definitely, thank you. Mental health is definitely an emerging priority. It's worsening now, and it's worse due to the pandemic. It's a disease of the 21st century, particularly now in the young. The pandemic caused a range of harms to children, from being isolated and lonely to suffering from things like sleep problems and social anxiety. 1 in 4 adults in England had a mental health condition in 2023-24. 1 in 4. The prevalence rates are particularly high and increasing for young people. Prevalence of common mental health conditions has been steadily rising since 1993, with significant increases since 2014. And the impact of the pandemic accelerated the trend of rising mental health. So the trend of rising mental illness um, was accelerated by the pandemic. People working from homes, children working remotely from school, causing social anxiety, panic attacks, and so on. So, just wanted to briefly touch on this as well. Long term conditions and anxiety and depression. Living with long term conditions significantly increases your risk of anxiety and depression, with about 30 to 40% of people with long term conditions experiencing these mental health issues. Common long term conditions like diabetes, heart disease often trigger emotional distress due to life changes, symptoms, and challenges. And we have to take a holistic view of long term conditions. We had a talk recently on lifestyle medicine. So, lifestyle medicine is really important for long term conditions. And around 40% of people with depression and anxiety also have a long term condition, such as cardiovascular disease, chronic obstructive pulmonary disease, diabetes, and around 30% of people with an LTC and 70% with medically unexplained symptoms also have mental health comorbidities. Common long-term conditions associated with anxiety and depression. So you've got diabetes, the really big one, diabetes type 2, cardiovascular disease, long COVID, osteoarthritis, and so on. Now we'll move on to the main bulk of the talk. Anxiety and depression is very, very common. It's extremely common. It's a deterioration in mental health. Its children are affected more than normal in schools. It's a disease of this century, the stress of life caused by the interaction of biopsychosocial factors, including genetic vulnerability. These interact with situation, stress, or trauma to produce anxiety. It's due to the fast pace of life, the instant on the go culture. We've got these instant cultures, we've got these iPhones, these iPads, these iWatches, instant culture, and it's the expectations of society as well. And I've seen it in my patients in Bromley, Croydon, even anxiety and depression in doctors, dentists, solicitors. So it's affecting every walk of life, really. And it's due to the pressure of work. And what we need to do is step back from the fast pace of life and create a space. So that's just want to reiterate that. Step back from the fast pace of life, create a space, put your iPhones away, put your iPads away for a few moments. I wanted to move on to talk about depression. Now, mental illness, my brain is very simple. I see mental illness very simply. You've got neurosis and you've got psychosis. So psychosis are those conditions with loss of contact with reality, such as psychotic illnesses such as schizophrenia, and neurosis are conditions such as anxiety and depression, where there's no loss of contact with depression. And broadly speaking, you can um, you can divide depression up into mild, moderate, and severe depression. Low mood being the main thing. You've got early morning wakening, people waking up at 2 or 3 in the morning, initial insomnia, difficulty getting off to sleep. Sleep issues are a real problem. Poor appetite, increased sometimes, poor concentration, tired all the time, fatigue, and anhedonia. So, what is anhedonia? Anhedonia is loss of interest in things that they normally like doing, poor libido, ruminations, overthinking, weight gain, or being disheveled. And then in moderate to severe depression, you've got thoughts of self harm. You've got fleeting thoughts of self harm in mild and moderate, but it's slightly more. We'll talk about how to assess the intent of the self harm. This is really, really important to be able to assess the intent of self harm, because in mild depression, you can have fleeting thoughts of self harm, which can be normal and they wouldn't necessarily act upon it. But if they made final plans, notes, final acts in things like moderate severe depression, you instantly seek help, whether it's through the crisis lines, the mental health crisis lines, A&E, the GP 111 999, or the Samaritans line. Samaritans have a very, very good line. That's 116 123. That's the Samaritans line, 116 123. Look at their family support. Are they living alone? Have they had a recent bereavement? Do they have a religious belief? Because they say sometimes that's a protective factor. And when to seek help, when there's thoughts of self-harm and they've made plans, when they've asked or done notes, and it's affecting work, activities of daily living, the biological symptoms of depression, ruminations, and when it's interfering with life generally, subjective distress. So the treatment of depression, so you've got mild depression. We're talking about counseling and talking therapies, which help you find ways to deal with emotional issues. So finding ways or plans or actions to deal with emotional issues. The Maudsley guidelines are Bible, the National Bible. Maudsley guidelines talk about mental health, and they talk about talking therapies in mild depression and things like bereavement counseling. In moderate and severe depression, you use things like medications such as SSRIs. They modify the neuronal transmission in the brain. And moderate to severe depression, the SSRIs are part of the NICE guidelines. And Cipriani's study mentioned two of the best, which were citalopram and sertraline. So my go-to medications for treating moderate to severe depression are citalopram and sertraline. Citalopram and escitalopram is good for anxiety as well as depression. They take 4 to 6 weeks to work, but normally can be quicker. You do get side effects, things like stomach upsets, GI symptoms, and generally people are on them for 6 months to a year. It can be longer, but you really want to be able to give a target line and to be able to wean the patient off the medication, ideally after a year. And you've got things like IAPT, improving access to psychological therapies, self-referral on the NHS. For instance, in Bromley, you've got Bromley Healthcare, self-referral to Mind, Samaritan's Line, and cognitive behavior therapy, which is really, really, we'll come on to that in a minute. So talking about cognitive behavior therapy, CBT can be done privately. It can be done through the NHS, talking therapies. And if there's an acute event, then the crisis line, Samaritans. And don't be afraid to ask for help. And this is for patients themselves. There's been a culture shift. Talking about mental health is no longer a taboo or stigma like it was before, when there was the pull yourself together culture, especially for men. And CBT can be done by trained psychologists, therapists. And I used to do CBT for things like OCD, obsessive compulsive disorder, when I was doing mental health training. So support and treatment for long-term conditions and anxiety and depression. So you've got integrated care services like NHS talking therapies. You've got psychological therapies such as CBT, and you've got self-management. Learning to manage worry and low mood can improve your ability to look after your physical health. So what is mental fitness? Exercise, going to the gym, even 2 or 3 times a day, two or three times a week, sorry, even for 10 to 15 minutes, using these aerobic. Everyone has these fancy step counters now, don't they, on your phones or on your watches, step counters, quantifying exercise goals, setting yourself simple, straightforward targets. Swimming is very therapeutic. Often physiotherapy, use water therapy as well. A Mediterranean diet, whole foods, fruits, vegetables, exercise, swimming, and things like apps as well. So younger people like to use apps quite a bit. So the app that's quite in vogue, I think it was Headspace app was quite good. Meditation is quite good. Some people find praying therapeutic. Self-help is good. Reading, walking, um, bird watching, gardening, for instance, during the pandemic, and early morning running, and diet as well to cut out carbs. Use things like proteins, decaf tea, cut out sugar, talking to family and friends, be open and honest, and hobbies as well, things like cinema and things like online. Everyone talks about Netflix and things like that. So it's the whole online things that you enjoy doing. So mental fitness, so diet, exercise, meditation, apps, therapy, hobbies, all these sort of things really. And I wanted to move on to anxiety. Well, I'm galloping through this because I know time is short and we want to do questions at the end. So, anxiety was worse during lockdown and particularly during homeschooling. And you've got anxiety can be split up into generalized anxiety disorder and panic disorder. So, generalized anxiety disorder is anxiety which is generalized and persistent, but not restricted to any particular circumstance. So, it's generalized and persistent but not restricted to any particular circumstance. So it's anxiety all the time, fear of impending doom, palpitations, fear when socializing, shortness of breath, feeling on edge, restlessness, sweating excessively. So that's generalized anxiety disorder, difficulty with sleep, headaches, and panic disorder is exactly what it sounds like. Sudden panic attacks, sudden fear, palpitations, sweating, chest pain, trembling, feeling of dread, choking sensation, dizziness, dry mouth, and it can last anywhere between 5 to 20 minutes. So it's exactly that panic attack. Suddenly people get this panic attack and they feel like they have to run. And when to seek help, when there's subjective distress. I mentioned subjective distress a couple of times. So what is subjective distress? It's a general uncomfortable feeling a person is experiencing affecting most aspects of his life, and when it interferes with work, home life, socializing, affecting children in schools, exams, and so on, that's when you seek help. And the management, so you've got talking therapies, you've got counseling, you've got CBT by things like a psychologist, and self referral to IAPT, improving access to psychological therapies, talking therapies, and CBT is one session every week for 5 to 20 sessions lasting 30 minutes per session. You've got over-the-counter medications. You've got things like Nitol, Calms, which you can go to any pharmacy in the UK and pick up for sleep and anxiety calms. St. John's Wort, more for depression, bereavement counselling, trauma tapping. So I put a link in there. You can have a look at that later. That's a new thing that they were looking at. And then moving swiftly on to medications. So medications for anxiety, really, really good are citalopram and escitalopram. And escitalopram works really, really well. They take 2 to 4 weeks to work. And please, please do not go down the benzodiazepine route, especially things like using diazepam. These are addictive medications and trigger long-lasting synaptic adaptations in the mesolimbic reward system that may ultimately induce pathological behavior. They might get addicted to the medication and want to have more and more inappropriately. And ultimately, for both depression and anxiety, refer to the CMHT, which is the Community Mental Health Team, which is led by the consultant psychiatrist, for a fuller diagnosis and a higher dose of medications, or even CPN input, which is a community psychiatric nurse. Mental fitness for anxiety, exercise, so things like swimming, socializing. Don't overthink. Notice when you're doing it and choose the present feeling. So pay attention to the present moment. And that is what mindfulness is. People talk about mindfulness, don't they? They say, what is mindfulness? And mindfulness is when you pay attention to the present moment, uh, inside and outside ourselves, including thoughts, feelings, and bodily sensation. So it's really about that and not overthinking things. Relax the mind, relax to read to a book, relax to music, prioritize sleep, about 8 hours ideally is what I normally take to people. Social prescribers talk about that. Create a routine and a ritual. So creating a routine and a ritual is actually quite helpful and is a good prognostic factor for depression and anxiety, and sometimes let go less responsibility. In OCD, they say sometimes people are made responsible too early. So don't take less responsibility, let go sometimes. Gardening, good posture, many physical back problems during the pandemic causing depression, anxiety, use of tramadol and things were due to things like posture and things. And don't use lorazepam, diazepam ever. I really can't emphasize that anymore. Walking. So even they say 10,000 steps, even if you can't do 10,000 steps, 4 to 5,000 steps initially, less TV, brain games such as Sudoku and chess and things like that. And briefly wanted to move on to preventing ill health in BAME groups, which is ethnic minority groups, basically to discuss um, ill health, mental health in ethnic minority groups. No doubt, many psychological and social factors to prevent this, but a very important factor is often not discussed. Health inequalities is due to several factors, whether it's diet, exercise, social class, background, all these factors. But health inequalities, often a very important factor, is often overlooked towards Black and ethnic minorities, and that is racism. Very subtle now. It's not like the old days. Well, I say that not like the old days, but when we were in this playground in the 80s, people were using the P word. Unfortunately, that's come back up again. It can be other very subtle examples, such as lack of eye contact from staff at medical institutions, being overlooked, talked at rather than to, assuming people have no medical awareness or knowledge. I mean, what that is basically stereotyping people and assumptions being made about people. Young Black men are 6 times more likely than white men to be sectioned under the Mental Health Act, and that's in the UK. And another anecdotal example is a lady who was wearing a headscarf, and she was told about how to use paracetamol and what paracetamol actually was. And it turned out she was actually a GP partner, GP principal of 20 years. And in an NHS patient survey, British Asians were 20% less likely to give a positive response to being treated with respect and dignity when compared to the white British group. So that's about respect and dignity. That's what it's all about. And Black and Asian minority ethnic communities with long-term conditions face disproportionate burdens of both physical and mental health issues due to systemic inequalities, cultural barriers, and economic disadvantage. So there's just some of the factors. However, having said all of that, talked about inequalities and discrimination and so on and so forth, people with mental health often are stigmatized in their own communities, in the BAME communities. It's a taboo. It's not to be talked about. If people have a mental health condition, they can often be labeled and stigmatized as a result of that. So we need to talk about it more openly and bring together communities from ethnic minorities, have leaflets and social groups discussing it in order to reduce the stigmatization. So webinars like this, podcasts that I've done as well, to reduce the stigmatization and to publicize. And it has to be seen as any other physical illness. So mental health has to be seen in any group, regardless of cultural group, as any other mental health. We need mood gyms, fun interactive programs to help people with low mood. I call it exercising the mind mood gyms, and it can include things like exercise, walking, healthy eating. Some people like praying, meditating, and we have apps such as Headspace, Calm, mood gyms, and you've got the Samaritans line. Talking to Samaritans is really good. And CBT, you can do CBT for post-traumatic stress disorder, eating disorder, anxiety, depression, anger management, addiction. And remember, you can do that by self-referral to IAPT. There's other things such as art therapy and light therapy as well. And I find light therapy absolutely fascinating. I actually saw light therapy in use only once in my lifetime. I went to a GP practice in remote Kent, and they actually had a room with wooden benches and white screens at the front, and that was they were using light therapy for people with low mood and depression. But however, the efficacy for seasonal affective disorder, which is when the weather is poor and mood is affected, is uncertain. So that's just a caveat. And I'm not sure if you've heard of trauma tapping. It's a tool used for PTSD stress relief. and emotional trauma. It's really, really effective. It's something that's come out quite new. They use trauma tapping techniques on the chest, and have things like WhatsApp groups, signal groups, help connect people with people who can be isolated. And I've noticed the elderly in the Asian communities can sometimes be isolated. So these groups can really help do that. And with elderly as a whole, it can be quite isolating. So keep in touch with your community. And there's high rates of depression and anxiety in the elderly Asian community. HealthETalks mentioned that. So the take-home point really for anxiety and depression is that mental health should be seen as any other physical illness. Any other physical illness. There shouldn't be any stigma, labeling, taboos about it. And we should try and normalize mental illness or mental health as a talking topic, um, in the same way that we talk about things like hypothyroidism, diabetes, asthma, COPD. We have to do that. And here are some of my references. I hope you found that useful. It's a gallop through anxiety and depression. It is a very hot day, and I know a lot of people couldn't come because it's Eid today. But it's a quick gallop through anxiety and depression, looking at lifestyle factors, anxiety, depression, things talking like swimming, diet, exercise, Mediterranean diet, avoiding carbohydrates, responsibility, CBT, trauma therapy, and so on. I hope you found that useful. So what we'll do now, I'll take any questions. If you want to put any questions in the chat, I'll take any questions in the chat. Does anyone have any questions? Please, I'm going to open the floor to any questions and comments, so feel free. Any questions, anyone? Does anyone have any questions? No? Anything anyone wants to say? Any comment? Yeah, so here we go. Can anxiety and depression be genetic? Yeah. So that's a very good factor. So there can be a genetic vulnerability to things like depression and anxiety. But as I mentioned, the sort of the multitude of factors that interact, the biopsychosocial factors that interact, can trigger that episode. But yes, there can be a genetic vulnerability, and you see that more in things like psychotic illnesses, such as schizophrenia and bipolar and things. There is definitely a genetic element to the psychotic illnesses, and but with depression and anxiety, there is. Yeah. You speak about another question. You speak about patients, but how about those working in profession? How common is this in the workplace? Yeah, so a good question, Katie. Um, Depression and anxiety is very, very common in the workplace. In my practice, in my surgery, so I was a partner a few years ago in Bromley. I used to see it all the time in the workplace, depression and anxiety. And it was worse before that as well, during the pandemic. So the pandemic really accelerated that deteriorating mental health. And it's very, very common. And as I mentioned also, I think I said it in my talk, Katie. I said that it can affect even doctors, dentists, solicitors, every walk of life. And people talk about socioeconomic deprivation and social class with mental illness. I don't think it's as simple as that. I've seen it affect every walk of life. I had a patient, an A&E consultant, who had depression, a doctor, a medical doctor, a dentist, and it's very, very common. I see it all the time. And so by taking measures ourselves, like I mentioned, things like, simple things like gardening, walking, swimming, exercise, diet, cycling, walking, bird watching, any of music, listening, praying, therapeutic, meditating, any of these things you can do yourself, and you can basically do your own mental fitness. It's like physical fitness, really. You just have to um, do mental fitness, really. So yeah. Any other questions? How long does an individual need to be on a medication for you for, and can you be weaned off? Or is it? Yeah, a very, very, very good question. So generally speaking, we have people on medications for a minimum of 6 months. So you want them to be on medications for a minimum of 6 months, and 6 months to a year. They don't have to be on them forever. A lot of people come off them after a year, 2 years. But generally speaking, the trend is people are on them 3 or 4 years before they wean themselves off the medication. And it is a tricky process. I'll be honest with you. Weaning somebody off an antidepressant can be a tricky process. You wean the medication down, monitoring for any relapse factors or trigger factors and so on. Yeah. Regarding prescribing meds, which medications you choose from your list and your preference doses? Yeah, so very, very, very good question. So um, I like to use citalopram and sertraline. Citalopram 20 milligrams for depression. And then if that doesn't work, sertraline, you've got sertraline 50 milligrams. You can go up to 100, 150. I think you better check that. 150, I think you can go up, if not higher, on sertraline. For anxiety, generalized anxiety, and even panic disorders, I like citalopram again, 20 milligrams. And I like escitalopram as well. Escitalopram, that's with an escitalopram. ICBs don't like us to prescribe escitalopram as much, so we prefer citalopram. But escitalopram is just as effective, and the research, I've got the Cipriani A study, which was a comparative efficacy study of 21 antidepressants. They came out quite high up on the list really. And it says here, are we given to understand that drugs, i.e., diazepam, can make the issue worse, especially anxiety? Could you elaborate that, please? Yeah. So, so diazepam it was a short term fix. People were given diazepam, fear of flying, fear of exams, were given 5 milligrams diazepam stat. And unfortunately, what happened was we found people were becoming addicted to the benzodiazepines, which are things like diazepam is a type of benzodiazepine. So people would become addictive. And so the effect eventually wore off and it became a pathological anxiety. People were becoming addicted to the drug itself, and not having it gave them anxiety. So it really was a vicious cycle. And really, I wouldn't recommend diazepam. If you really, really have to, if it's something really pressing, like someone's having a severe anxiety into an MRI scanner, you can use short-acting lorazepam, for instance, very, very occasionally, and I wouldn't recommend it, but you can use short-acting lorazepam if you need to. But try and stay clear. Very good question, Jenny. Try and stay clear from diazepam, and it can make things worse. So be wary of that. And another question from Olena: how to wean off the medication? So weaning off, if you're on an antidepressant, I don't know if you meant antidepressant or whether you meant the benzodiazepines, you have to do it in a tapered way. So if you're on an antidepressant, citalopram 20 milligrams once a day, you do 20 milligrams once every other day for 2 to 4 weeks, then once every second day, and then you come off. So you taper the medication gradually, monitoring for relapse factors, monitoring for factors for depression and anxiety, making sure they don't relapse back into that state. So it has to be done very gently over time and carefully. And if you mean weaning off things like diazepam and lorazepam, that's a very tricky area. Again, a tapering dosage of reducing regime over periods of weeks, and monitoring for you know dependence symptoms and anxiety and so on. And it says here, how can I tell the difference between a real immediate danger and just an anxious thought or a false alarm? So yeah, it's a good question. So people with generalized anxiety or panic disorders can sometimes have a rational fear which becomes irrational. So give you an example. This was during the pandemic, just after the pandemic, people were doing the 11 plus exam, but in Sutton, for instance, and children developed panic attacks. Basically, they had this fear of the exam, and they had this intense panic attack. And people were running out of the exam hall, and that's when it becomes, real anxious thought, really, a panic attack, more than just a normal thought. Normal immediate dangers, our bodies respond. We get palpitations, sweating, anxiety, heightened fear, heightened arousal, and we can see a stimuli for it generally. But it can happen without stimuli, with or without stimuli, either or. So it often becomes an irrational fear. And generalized anxiety, Rafi, to answer your question, is anxiety which is there all the time. It's generalized, it's persistent, not related to a specific instance or a trigger. And from find that when patients have exhausted multiple and therefore little options left, General practice is still struggling with their mental health. Referral then to secondary often gets rejected. What did you say? Yeah, very good point. Yeah, from MPS. Very, very good point. Happens to me all the time. It happens to me all the time. I worked in mental health. I did psychiatry, and now I'm a gypsy in mental health. So I'd like to refer a patient to mental health. Referrals rejected straight away. Not appropriate for mental health services. What do? You refer back, rejected. So what you really must do is you have to talk about things like you've tried multiple medications, if necessary, at higher doses. So you might have tried things like citalopram, sertraline at 150, 200 milligrams, citalopram at 40 milligram higher doses. You might have tried an SNRI. You might have tried venlafaxine, which is an SNRI, which is really good. You might have tried escitalopram. You might have tried things like vertoxetine, the newer antidepressant. You've tried all of these medications and you've assessed the intent. There might be intent of self-harm. So have they done a plan? Have they made a final act? Have they said goodbye to everyone? So assess the intent of their self-harm. You've tried numerous medications. They're not helped by those medications, and it's interfering with their ADLs, their activities of daily living. It's interfering with their work. It's interfering with their school life, their work life, their home life, and as such, they need specialist input for specialist higher dose medications, or whether we need further medication. And what I would also put in there, they always do this, don't they? When you send them to psychiatric liaison or an A&E, they always say exclude physical causes, which is correct, and that's correct. So maybe make sure before you do the secondary care referral, you do blood tests. So things like thyroid is hypothyroidism, check for TFTs, check their blood sugar, check their full blood count, liver function, kidney function. Make sure there's no sort of any factor that could precipitate a delirium, an acute confusional state or something. So do all the bloods, put them on a couple of medications if it hasn't helped. Try referring them to talking therapies, IAPs, so improving access to psychological therapies. A really important point, guys. Improving access to psychological therapies or talking therapies, you can self-refer yourself to talking therapies. So that's really important. So the patient can self-refer themselves for talking. They're a really, really important point, and it can reduce the burden of workload for GPs as well. And do you try the previous medications again alongside the lifestyle change? So I probably wouldn't try the previous medications again if they haven't worked. I would do the lifestyle changes. So having the lifestyle medicine is really big now. Having the lifestyle changes, having the lifestyle medicine, but trying newer antidepressants, so such as vertoxetine or venlafaxine or citalopram, escitalopram, sertraline, all these types of medications. You said, what are your thoughts on starting vertoxetine? Yeah, someone's asked that question. Yeah, excellent. Yeah. So yeah, vertoxetine, very, very good antidepressant, works really, really well. People have given me good anecdotal evidence. There's good evidence in the literature as well, but in the anecdotal evidence from patients is that vertoxetine is really, really good, and finding it helpful for patients who have been on multiple SSRIs, on citalopram, sertraline, escitalopram, and then the start of vertoxetine. I often find sometimes using mirtazapine alongside strategies is helpful. Have you seen this in mental health? Can you use mirtazapine alongside? Yeah, I generally don't use mirtazapine alongside another antidepressant. Mirtazapine does have its place, especially when sleep is affected. So when there's initial insomnia, difficulty getting off to sleep, when there's early morning wakening, and problems with sleep and sleep hygiene, I find that mirtazapine works really well. It does have a sedative effect, which can work against people as well. Some people find they're too sleepy to go to work, for instance, in the morning. So I look to the minimum effective dose. Always try to, once you've got the patient in remission, try and get them to the minimum effective dose so that you can taper the medication down to a lowest dose so the side effect profile is low. So yeah, mirtazapine has its place, definitely. I generally don't use it with other antidepressants together, but definitely one to use when sleep is an issue. And another question is there anything you can do within your surgery to offer support to those experiencing early signs of mental health crisis, or is it down to the individual to come to you for help? Yeah, I mean, we in Bromley we had these cafes and coffee mornings. So we had coffee mornings. There's mental health cafes. There was one in Beckenham, I think, to encourage people to come together and come to the mental health hub and to talk about crises. And you can reach out to people, but it is difficult. It is time consuming. It's generally down to people themselves to try and seek out help from people in primary care and primary care clinicians, so to reach out and ask for help, um, and that's the main mode of action. It's mainly more we reach out. It could be if there's a psychotic illness. So if someone's got a acute psychosis, which is psychosis means loss of contact with reality. If they've got an acute psychotic illness, then they lack insight, so they're not aware they're ill. That's when we have to reach out. You might have family or friends contacting you and saying this person is hearing voices or they're having paranoid thoughts. They believe that the police is after them, or so on and so forth. So you have to be really, really careful and mindful of psychotic illnesses, and that's when you do have to reach out to illness. And that's another topic, another talk for another day, because today we talked about neurotic illnesses. And so then someone says, how do you deal with depression in children? So very good question. So talking therapies, counseling, uh, counseling, school counselors. You've got school counselors in certain schools, and you can use SSRIs in under 18s. I think it has a very low dose. I think it's 10 milligrams. I think it's something like fluoxetine. You'll have to check that, but I think something I wouldn't start that without specialist input and getting an approval or a discussion with a specialist psychiatrist. Something like if they're 17 years old or 16 years old, starting something like fluoxetine 10 milligrams, but checking that and confirming that with a specialist before you do that, because you don't really want to be giving antidepressants to children. I don't like the idea of that. Sometimes you have to, but that's a different topic. So do get CAMS involved, child and adolescent mental health services involved, if you believe that they need antidepressants. But talking therapies, counselling, school counselors, and nowadays I was in a school recently and they had a school dog, and just in a therapy room they had a therapy room for the children. I thought it was a fantastic idea. I didn't have that when I was growing up in school, but I think that's a fantastic idea, these sort of things. So dealing with mental health in children. Could we have the slides email? Yes, Jenny. So what we'll do is because a lot of people couldn't come today, as I said, because of Eid, celebrating Eid today. What we're going to do is we're going to email out the slides to you at the end, and make sure you get a copy of the slides as well. So that's really good. Yes, and yes, Katie said that should have, so thank you for that. And another question is, people are on long-term antidepressants, aged over 65 or turn 65. So citalopram maximum 20 milligram, but they are on 14 patients reluctant to reduce. Is it okay to continue if normal ECG and understand risks, or do you reduce? It's a very good question, MPS. Very, 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 very good question. Generally, the recommended dose in the elderly is 20 milligrams, but you do often have people who have been on 40 milligrams all their lives, and then they turn into the age threshold over 65, and then they're on 40 milligrams. You can continue initially if you do an ECG, so check for ECG changes, do their annual bloods, but you really want to be reducing that dose as they get a little bit older, because the body won't need as much medication as they get a little bit older. They might get frail, thinner, BMI might reduce, and so on and so forth. So you might want to reduce that medication if they absolutely can't. If you reduce them down from 40 milligrams to 20 milligrams and they are showing signs of relapse, not eating, and depression in the elderly can present as something called pseudo dementia. So pseudo dementia is depression in the elderly. It can present like dementia, but it's actually depression in the elderly. So be careful of that. Watch out for that one. So if you reduce that and you're seeing signs of depression, you might have to, if the benefits outweigh the risks, you might have to keep them on the 40 milligrams. And you can even try an intermediate dose like 30 milligrams or one every other day, to try every other day, or to go to an in-between dose if possible. But the ideal is to taper the medication. But as you say, that's not always possible. I've had that scenario where I've had patients who are 60 and then and basically they turn 65 and then they're still on the higher dose, but when they're not able to wean themselves off the medication. So it is a very tricky area. And that's when you can get social prescribers involved. So social prescribers are absolutely fantastic. Social prescribers, mental health practitioners. We've got MHPs in GP surgeries nowadays looking at SMIs, the severe mental illness, physical health checks for SMIs and so on. So it can be there's a lot of value and merit in having social prescribers and MHPs maybe taking over where we don't have the time. We only have 10 minutes. I have 10 minutes to go through a whole mental health consultation, and boy, is it tiring, and boy, is it hard work. So if you've got mental health practitioners, social prescribers, do use them and see if they can help you reduce that. And even pharmacists nowadays. So the local pharmacists sometimes have pharmacists who call the patients to try and reduce their medication or to talk to them about the medications, or PCN pharmacists as well. So PCN pharmacists are really good. PCN pharmacists can sometimes help with reducing medications or do medication reviews, medication checks, and so on. And someone said here, my GP gives escitalopram instead of citalopram. Yeah, some people do use escitalopram. And as I said, I mentioned escitalopram in my talk, didn't I? I talked about escitalopram particularly for anxiety, generalized anxiety, and for panic disorder. I do like escitalopram, but I use it at a lower dose. So in the elderly, I would use it maybe at 10 milligrams. So instead of 20 milligrams, I would use escitalopram at 10 milligrams, and you can use that for depression and anxiety. But citalopram is recommended slightly more. But yeah, that's a valid point. No, I appreciate that. Can I have can I have the name of that new antidepressant again? Yeah, it's called Vertoxetine, Jenny. Vertoxetine. If you scroll up in the chat, I think M. Pierce has written it on there as well. Um, Vertoxetine. Vertoxetine. I'll write it down for you if I can. Yeah. And another one to use is venlafaxine as well. So venlafaxine, you probably know venlafaxine. Venlafaxine and Vertoxetine. I don't know if I spelt that correctly. I'm writing and sharing and talking at the same time. So Vertoxetine and venlafaxine, very, very good antidepressant. Venlafaxine, when it came out, I was doing mental health at the time. It's an SNRI, so it's a selective serotonin and noradrenaline reuptake inhibitor. So it does both chemicals in the brain. So it works really, really well. It was good, but nowadays it's slightly out of vogue and GPs use it less. Another question: if people are on long-term antidepressant, aged over 65, and turn 65, is it okay to? Yeah, we've done that one. The toxicity. Yeah, thank you for that, Rafi. And the slides, as Rafi has said, the slides will be emailed to you all at the end, because there's a lot of people who registered who weren't here today, so we will be emailing the slides over to you as well. So you've got a copy of the slides as well. But I think that was a whistle stop tour um, through anxiety and depression. I hope you found that useful. I tried to give insights from a GP's point of view. I tried to talk about mental fitness for staff, for colleagues, for yourself, and then I tried to look at it from different angles as well. We looked at when to involve secondary care services, to use lower doses, so citalopram 20, really max ideally in over 65, fluoxetine maybe 10 with CAMS input for under 18s, ideally avoid more talking therapies, and then antidepressants, so citalopram and sertraline for antidepressants, and for anxiety, citalopram. So another question: how do you go about helping a young adult whom you know is depressed but they refuse to start meds? They believe they will have to take meds long. How do you start that convo? Yeah, very, 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 very good question, Satrapa. Very, very good question. How do you start that conversation? I think the main way to do it is to normalize it. So, like I was trying to say, to try and normalize and reduce stigma, labeling, stereotyping in any community. We have to talk about mental health openly and honestly with everyone. And there are certain communities where it's still a taboo and it's still a cultural bound. They don't talk about it as much. So talk to them openly. Say it's very, very common. As I mentioned, I think I mentioned, did I say 1 in 4 in 23, 24 in that year had some form of mental health condition? So talk to them, open up the conversation and say mental health is very, very common. Everyone's got some problem. Everyone's on some sort of medication. It's completely acceptable. It's completely normal. And you will come out of it. You will get better if you take help from talking therapies by referring yourself or going for cognitive therapy or going to see your GP. Ideally, see your GP initially, and you can discuss medications or therapy or counseling. So to try and normalize that conversation. Um, I think so. Try and normalize the conversation, and basically, and that's how you start the conversation. And maybe even go with them. Maybe even go with them if you can, if they don't mind. If they don't mind being stereotyped or they're worried about being stigmatized, go with them and say, "I'll come with you, and we'll have a chat together." And often nowadays you don't even need to go. You can do telephone consultations, you can do video consultations. There's GP platforms out there now that are doing um basically doing video consultations and telephone, and your GP can do telephone consultations as well. So it reduces the burden of anxiety, going like in the old days, when you're going to see your GP, the family doctor, when it was in the old days, you would see um your GP. You'd have your own family doctor and you'd have to go and see him, and it'd be quite a palaver. It'd be a big event. But nowadays it's not that difficult. Access is much easier to GPs, counselors, therapists, talking therapy, all of these people. You can do it via telephone, you can do a video, you can even do a private consultation with a GP video consultation, or your GP. So it's nothing to be worried about. But just try and open the conversation and invite them to these forums and webinars. Maybe you could even send them a copy of this webinar, and or one of my podcasts that I've done where we talk about mental health openly and honestly. So that's fine. And yeah, Jenny, as Rafi said, no need to email your email. We've got your emails registered from the people because we had a registration link on the talking on the webinar. So I think that's it. Any other last burning questions before I? There's 1:49. I am conscious of time during the middle of the day. So any burning last question before I close the event? No? Lovely. So I just wanted to say thank you all for coming. Thank you all for making this possible. Thank you to Rafi and Katie and everyone at Neighbourhood Health Group for making this happen today. I really appreciate that, to bring the conversation out in the open. And basically, thank you all, everyone who attended, all the attendees, really good turnout. And any questions, you can get my email from the registration, and you can email. I don't mind being emailed. You can email me. You can email me, and we can take any questions. You've got personal questions to do with mental health. So thank you all for listening, everybody. Hope you have a great day, and happy Eid to all of those who are celebrating. Thank you. All the best. Take care. Bye.